webinar, Mental Health Needs and Service Use Among Young Adults Experiencing Homelessness. I'm Emily Taylor, Dissemination Manager for Pathways, and I'd like to begin with a few housekeeping announcements. Please see the advice on this slide to make the most of your GoToMeeting experience. In particular, note that during the presentation, all audience members will be muted, but you can send your questions to us via the chat feature, and we'll save some time at the end to answer as many questions as we can. A recording of this webinar, along with a downloadable PDF presentation, will be made available shortly after this webinar ends and will be available from the link shown below. And we'd like to invite everyone who registered for this webinar to stay in touch with Pathways by signing up for our monthly email newsletter, RTC Updates. We feature links to Pathways resources and like this webinar, as well as news and events of interest to the field. You'll receive an invitation via email after this webinar, and we hope you'll accept it. This webinar was made possible through funding from SAMHSA and NIDLR. And with that, welcome to today's webinar, Mental Health Needs and Service Use Among Young Adults Experiencing Homelessness. Our presenters today are Sarah Carter-Narendorf from the University of Houston Graduate School of Social Work and Matthew Uretsky from the Portland State University School of Social Work. Let's let each of them introduce themselves, please. Sarah?
Hello, I'm Sarah Narendorf. I'm an assistant professor at the Graduate College of Social Work at the University of Houston. My research focuses on the transition to adulthood for young people who are vulnerable for various reasons, including experiencing homelessness, aging out of the foster care system or the juvenile justice system. And I'm particularly interested in the intersection of mental health with those experiences.
Hi, I'm Matthew Uretsky, and I'm an assistant professor at Portland State University School of Social Work. And my research is mostly focused on the obstacles to educational success, especially as youth are moving into or out of the K-12 system.
Fantastic. We're so glad to have you both here. Before we start the presentation, let's do a quick poll and just get a sense of who is on our call today. If our attendees would please respond to this and just give us a sense of your role. All right. So already we have about 75% have responded, and about equal, 73% are service providers or managers, and 13% are evaluators or researchers. So that's pretty interesting. I think we'll just give one more second for any more responses. Okay. Now, can hopefully see those results. Great. Thank you so much for responding to that. Now we'll go on to the presentation. Sarah, I'll give it to you.
Okay, great. Well, I'll just go over our agenda for today, which involves, first we're given an overview of homelessness in transition age youth. Matthew will talk some about some of the definitions and the numbers that we see. Then I'll talk some about the intersection of homelessness and mental health and some related concerns that you want to be thinking about, just thinking about this population. And then I'll move into talking about the Homeless Youth Risk and Resilience Study, which is new research that involves a survey of homeless youth from multiple cities across the country. And we'll present findings specifically focused on mental health needs, mental health service use, help seeking, and coping from that survey. And then we'll pull it back out and talk some about implications for intervention and prevention.
So first, I just want to take a minute and provide some definitions that are used for homelessness among youth and young adults. And there's two major areas where definitions are important. One is McKinney-Vento, which is it's the federal law that outlines the rights and responsibilities and services provided for families that are experiencing homelessness or transitionally housed families in the school system, in the K-12 school system. as well as early childhood. And there's some rules that help with college access as well. And then the HUD definition, which really focuses on housing and housing programs and eligibility for those programs. Historically, the HUD definition was much stricter than the McKinney-Vento definition of homelessness, but over time they've actually dovetailed quite a bit, and now they're pretty much in line with each other. And really what you're looking for when you're trying to understand if someone qualifies under these programs is whether they lack a fixed, regular, and adequate nighttime residence. So, for example, are they staying the same place that they were tonight as they were last night or next week? Is it regular? Can they stay there anytime they need to? And is it adequate? Is it meant for human habitation? Does it have plumbing? Do they have their own rooms? They have keys to get into the house and out of the house. Do you have a legal right to live there? So places like motels, camping grounds, as well as doubled up and couch surfing would qualify. So some of, just to point out how the programmatic features between HUD and the McKinney-Vento program really create, even though you have the same definitions, actually some of the availability of services will restrict how many people are counted. So, for example, in 2014 and 15, HUD identified 61,000 children living with adults in a homeless situation, where under the same definition, McKinney-Vento found over 1 million. The same with unaccompanied youth. The McKinney-Vento program identified about 3 times more unaccompanied youth, which means living without an adult or a legal guardian, than the HUD program did. And just to give you a sense of how many 9th to 12th graders you'll see in the population among McKinney-Vento students, you get about 323,000 high school age students. And the HUD also identifies youth up to 24 years old, which is a little different, and they've found about 50,000. But you can imagine, just based on the capacity and eligibility requirements and the ability to serve, there's probably quite a few more students out there and young people out there experiencing homelessness than are counted in these numbers. And just to give you a sense about how people are counted, you could look and see here they have only about 14% of the people that were counted as homeless at the school districts were living in shelters or transitional housing, and about 2/3 were doubled up. And the doubled up are much harder to identify, as you can imagine. There's no flag or indicator or anything that pops up above a student when suddenly they move in with a cousin or an aunt or an uncle or a friend and are staying on their couch because their housing has changed. They're going to wear their same clothes, and unless they're trying to access services, you probably will not know that they've become homeless during the school year. So most of them are identified as they try to enroll in a school and don't have a proof of residence. So it's really important to think about how much of the population is likely invisible and how few of the families are actually living in shelters as most of us imagine. And another thing to remember is a lot of the research that is done on homeless students or transitional students comes from the sheltered population because they're so much easier to identify and access. So everything's a little skewed towards that. So just to give you a little sense of some of the challenges and barriers to self-identification experienced by homeless youth, I just want to briefly talk about some of what we've learned from the research literature. Overall, students experiencing homelessness are more likely to have health problems like respiratory infections, stomach and diarrheal infections, emergency hospitalizations, and other things such as speech and stammering problems and asthma. And this is both due to lack of care, the conditions that they're living in, but also the stress and trauma that they're going through that's kind of having a psychosomatic effect on them. So they also tend to experience poor academic adjustment. So poor attendance, grade repetition, lower standardized test scores, and then more behavioral issues. It's also interesting to just think that, to point out that students that are living in shelters tend to perform worse in school than students that are doubled up and living with friends or family. So really thinking about even at-risk reduction if you can't completely solve the issue. Finally, really thinking about the elevated psychosocial risk, the behavioral mental health difficulty, and the experience to violence and social stigma, and also thinking about identifying youth, especially as they get older in the population we're talking about. We just know much less about homeless youth in high school and beyond. They're severely underidentified, and they're increasingly disconnected from formal services. And really, unless we as service providers are offering something that's very meaningful and something that can really solve pressing issues in their lives or address some of their pressing issues, there's very, very few reasons for them to self-identify and go through the stigma of letting others know about their housing situation.
So I'm going to talk a little bit about the intersection of homelessness and mental health. And so what generally research has drawn from samples of young people that are in homeless shelters, in homeless serving organizations or on the streets. And in those populations, we see really high rates of mental health problems, of course, depending on how you operationalize that or how you think about what is a mental health problem. There are rates that range from 50 to 90% that include disorders like conduct disorder, oppositional defiant disorder, substance use disorders, but also a lot of mood disorders, and then also lots of comorbidity across. So young people are likely to have not just one, but several disorders happening at the same time. So we have some pretty good documentation that there are high rates of problems in young people that experience homelessness. And the reason for that, there's really a bidirectional relationship between mental health and homelessness. And so what we see is that mental health problems are an underlying risk factor for housing instability, but then housing instability also increases the risk for mental health problems. So we see those two things kind of going hand in hand. And then underlying both of those things is several other important things to think about. So one of those is trauma. So trauma contributes both to housing instability. It may be part of the story of why somebody became homeless in the first place. And trauma is also, strongly associated with mental health problems. We have that kind of a shared risk underlying. Then system involvement is something that we see a lot of in young people who experience housing instability or homelessness. Many have aged out of systems like the foster care or juvenile justice system, which is a sort of particular point of intervention for us to be thinking about, since there is sort of a system involved that we know as a potential point of intervention. But unfortunately, many young people come out of those systems and end up experiencing housing instability and mental health problems. There's also substance use is a prominent aspect of this whole picture. So substance use can contribute to housing instability. We see that in the stories of how young people became homeless. Sometimes substance use is involved and sort of creates and fuels family conflict. Substance use also is related to mental health problems. We hear young people talking about managing their mental health problems with substances, and then being on the streets also puts you at higher risk for using substances. And of course, disrupted relationships, both family relationships and strained support systems are pretty prevalent and also sort of exacerbate the situation, which increase both mental health problems and housing instability. So when we're talking about this population, we see a lot of factors, kind of risk factors, kind of showing themselves all at the same time. So it's a complex population with a lot going on that we want to be thinking about and effectively supporting and working with young people, these young people. So I'm going to shift to talk a little bit about the Homeless Youth Risk and Resilience Survey, which is a collaboration of researchers who we got together. The next slide has the list of researchers. That's the team from across the different cities. And basically it's a group of researchers who got together and designed a survey instrument together. So we worked together to create a shared instrument that would be given in all the different cities and shared procedures to identify young people and administer the survey. And then each city conducted its own study, which we're able to combine the results on the back end, and that's what I'll be talking about today. So I'm sharing some of our first results, but it's certainly not just my work, but the work of many researchers. So in terms of our eligibility criteria, young people in the survey were between ages 18 to 26. And just to note that we use the term youth, and even HUD uses the term youth, and that applies to young people up through age 25 or 26. So when we talk about homeless youth, we're talking about young people that are both in high school, but also many that are young adults. So it really spans that transition age. For our survey, they had to be homeless or housed with a voucher, and we defined homelessness pretty broadly to include young people that were couch surfing, as well as those that were on the streets or staying in a shelter. We all interviewed and recruited young people at homeless youth specific service providing agencies. So I'm in Houston, and for example, in Houston, we were at the Covenant House, which is a shelter for 18 to 21-year-olds in Houston, and then also at a drop-in center specifically for young adults run by the Salvation Army. At each city, we had around 200. We all shot for, our aim was to get 200 young people. And then we also did qualitative interviews with a subgroup of those young people. And so I'll be presenting some data that includes the voices of young people to help kind of understand some of those quantitative results. The time frame for the survey, we, in Houston, for example, each city, we started in the summer of 2016 and ended in the summer of 2017, and the pace was a little bit different depending on which city you were in, but it was over several months. We started in summer and went into the fall in Houston. So I know we had questions last time about maybe, did the weather impact, and I think really we have that probably wasn't really influencing who we got in the survey. And then the young people completed surveys on iPads. They were self-administered. So the next slide has the participants, just some demographics about them. So we have a sample of over 1,400 young people with a mean age of a little less than 21. It's disproportionately male, and also we have 8% transgender or other gender identified, and so that's exciting. It gives us the opportunity to look a little bit more at the experiences of that population specifically in future work that we do. In terms of sexual orientation, 28% of the sample identified as LGBTQ. The most predominant living situation was shelters, though we have about a third on the streets. And then in terms of race ethnicity, we have a fairly even distribution, though our largest group is African American young people. So in terms of just giving you some context about the risk and resilience factors for the sample that kind of align with some of the things I talked about earlier, we did see that almost 40% had been in foster care at some point in their lives. So similar to what we saw in other research, our sample is similar in having a lot of system involvement. 37% had been involved with juvenile justice. And then, each of those 17% had aged out of foster care, 14% aged out of juvenile justice. So, just something to think about in terms of planning for discharge and ways that we can better facilitate housing stability as these young people are on their way out of these systems is certainly a target for intervention. In terms of other factors, almost half had been arrested. So involvement with the criminal justice system is certainly prominent. And partnering with criminal justice and thinking about ways to intervene, to work with the criminal justice system is something to have on the radar when you're thinking about service delivery for this population. Almost a half had evidence of a substance use problem. So comorbidity with substance use and mental health problems is prevalent. We saw that in our sample. Also trauma, the prominence of trauma, we gave the Adverse Childhood Experiences Scale, which is asks about 10 different traumatic experiences. So a score of 4.6 means that the average young person in our sample had experienced over 4 traumatic events. And just to compare, in the general population, that's less than 2. And so we're seeing young people that have quite a high levels of trauma exposure. On the flip side, in terms of resilience, 69% had at least a high school diploma or a GED, which really is something to build on in terms of how do we support young people in moving ahead and becoming self-sufficient. So a lot of them do have a high school diploma or GED credential. And then a third of them are working. So and I'm going to focus now specifically on mental health need, although actually I did want to mention that somebody had asked at our last webinar about gang involvement, and it wasn't on the slide there, but I did look at that. So 20% had been involved with a gang, in case you're interested in that, may go along with some of these other risk factors. So in terms of mental health need now, we had 3 different standardized screening measures that we use to measure mental health needs. So these are screeners where young people are asked about specific symptoms, and then based on their answers, we score whether or not they screen positive. So we have one for depression, that was current depression. We have a screener for psychological distress, which looked at the past year. And then we have a PTSD screener, which was also recent current PTSD symptoms. And we also asked items about suicidal ideation and suicide attempts. So those are our measures of measured mental health need. We also had a couple other ways we looked at mental health need. One was historical. So basically that's asking young people, had they ever been diagnosed with ADHD, depression, bipolar, schizophrenia, or oppositional defiant or conduct disorder. And that gives us a sense for their history and also their contact with mental health service providers who would have given them a diagnosis, because the question actually asked specifically about if they had been diagnosed by a mental health professional. We're also particularly interested in what the young people perceived themselves. Did they actually think that they had a mental health problem? Did they think they needed treatment? So we asked questions about that as well. So in terms of findings related to our measured mental health need, those are those screening items. We had 48% that screened positive for depression, 41% for psychological distress, and 39% for PTSD. And those are all considerably higher than what you'll see with these screening instruments in other samples, like college students, for example. We'll see like 8 to 9% on these measures. So these numbers are quite elevated. Not surprising among homeless young people, but it is further evidence that really active mental health challenges are present in this group. The purple bar there shows that 65% of young people in our sample, so almost 2/3, screened positive on one of the 3 screening measures. So we use that as a gauge for, did we have some evidence based on the questions that we asked them about whether there was a mental health need or not. So 65%, we did see some evidence of that. Also want to note that there was pretty extensive suicidal ideation and attempts. Just less than 1% of the general population will respond that they've had a suicide attempt in the past year in the same age group. So 14% is pretty high. So that's also something to be thinking about and really screening for and paying attention to in this population. So who is at highest risk? So we're looked at that purple bar, that 65%. That's pretty high, just baseline. If you're in our sample, you're at pretty high risk. But there were certain subgroups that had higher risk even than that 65%. So those who identified as LGBTQ were at heightened risk. So that's 28% of the overall sample. And so it's sort of, that is disproportionate. LGBTQ people experience homelessness disproportionately. And those young people are at elevated mental health risk even compared to other homeless young people. So that's just something to be thinking about and really paying attention to. Also, those who identified as female were at higher risk for mental health challenges. Also, those who were transgender compared to male, 71% with mental health need identified. We saw differences in race in the rates of white youth who are at higher risk compared to young people who are African American who screened at lower risk. We're really investigating that a little bit further, but one thing that may feed into that is the reasons that young people become homeless for white young people seems to be a little bit more driven by pre-existing mental health and substance use problems, while for African American young people there may be more poverty and disrupted social supports that may feed into those differences. Those with substance use problems, we saw really high rates of mental health need. So once again, highlighting the just high rates of comorbidity. If you've got a mental health challenge, there's also a high chance that there's substance use involved too. Trauma, again, the ACE score is what I talked about before. In the overall sample, it was 4.6. And here, for those who screened positive for a mental health problem, it's even higher. And then there's some things that were not related that are kind of interesting. Living situation was not related to mental health needs. So those who were on the streets were not in a worse, had screening for higher rates of mental health challenges than those who were in shelters or living doubled up. Things that we thought would be protective, like working or having a higher level of education, also were not associated. And system involvement and arrest also didn't change your mental health, the rates of mental health need in those groups. So in terms of mental health need historically, we did see evidence that a lot of young people had received diagnoses in the past. 37% had been diagnosed with ADHD, mood disorders, depression, bipolar, 33 and 36%. And then many fewer had reported a diagnosis of PTSD, which I think is just something to note in comparison to sort of the number, almost 40% screened positive as currently having PTSD symptoms. PTSD seems to be diagnosed a lot less, even though we have some other indicators that seem to indicate that trauma is pretty present in this group. So the next slide talks about perceived need. So while we had 65% that we saw some indicator based on our screening measures that there might be a mental health problem, and when we asked the young people themselves, do they have a mental health problem, 54% said no, they do not. 28% said yes, so they strongly identified, they were saying for themselves, yes, I have a mental health problem. And then another 18% said they were not sure. In terms of trying to kind of disentangle a little bit, so you might say that you don't have a mental health need because you really don't. And then you might also say because you're not really recognizing symptoms you're experiencing as a mental health problem, or you don't sort of want to endorse that kind of language. So we tried to look at the intersection of, based on our indicator of mental health need, that purple 65%. So how many of those, how did that line up with what young people perceive themselves? So 85% of those who said they were currently experiencing a mental health problem had an indicator of mental health needs. So that was pretty high, not 100%, but pretty close. And then a similar percentage for those who said they didn't know. Actually, 84% of those were had screened in the group who met criteria on one of our screening measures. But almost 50% of those who said they were not currently experiencing a mental health problem did screen positive on one of our measures as actually experiencing it. So we're kind of interested in that group as like who is that? Who's more likely to have some indicator on our screening measures that there's a problem, but not identify it themselves? And so the things that are associated with that were being heterosexual, male, Hispanic, or African American. So some of the indicators, this is consistent with other research about who actually gets mental health treatment. Males are less likely than females. So young men of color, I think in particular, sort of are less likely to identify themselves as having a mental health problem, even though they might screen positive on a measure that would suggest that maybe they do have a problem. So I'm going to present a couple of quotes just so you can hear the language the young people talked about in our qualitative interviews. So these are young people who both had a measured need on our screener and said for themselves, yes, I do have a mental health problem. So one young person said, I do have very bad anxiety, and I do have a bipolar disorder as well. because one minute I can be flowers and cupcakes, and the next second I can be really mean. And then another young person said, I do know I have ADHD, and I do know it's very severe, but I've been able to control that a little bit. I feel like I'm not bipolar. I just feel like if you piss me off or make me mad, everybody gets upset. And so I think the second quote highlights, too, that young people, some of the young people in our sample had received multiple diagnoses over time. That's something that we know young people in the foster care system in particular experience. And at this point, they have gotten, this young person had gotten to the point where they're able to say, yeah, some of those symptoms and one of those diagnoses I do identify with, and there's another one that actually I don't think fits me. So I think it kind of highlights the fact that young people have been living with these diagnoses and these symptoms, and they have their own opinions and thoughts about what fits for them. So I think we see those in these quotes. The next set of quotes is from young people who are a little bit uncertain. It fell in the don't know or the no, I don't have a problem. So the first person is somebody who has a history of a diagnosis but says, no, they currently don't have a mental health problem. You know, I don't know if I am bipolar. I don't think I am. I just think I'm too damn real for this, and I have a low tolerance for stuff. So this is somebody who's screened positive, but themselves does not identify that. And the second is somebody who says, I don't know. And I think as we listen to the quote, I think the person kind of doesn't know if they have a problem right now, but has a sense that mental health problems are somewhat chronic. So they say, I think you can't really get rid of mental illnesses. Like, people will think if you're acting okay, you don't have them anymore, so you can function like everyone. But they always forget that you still have them and that you still have to try differently from others. So our next set of slides is about mental health service use. Young people had pretty extensive experiences of mental health treatment. A lot of them had taken medications, psychiatric medications at some point. The blue bars are lifetime, so 44% had taken medications at some point in their life. The red bars are in the past year. The ever statistics are pretty similar to rates of service use in young adults who have some kind of indicator of mental health need. So this isn't extraordinarily high, but what does really jump out are the emergency room and inpatient hospitalization rates, which are much higher than other young people with mental health challenges in this age group. So we're seeing a lot of emergency-oriented service use in this group, not surprisingly, but something to be really thinking about and paying attention, that many have been to the emergency room and had an inpatient or had an inpatient hospitalization at some point. We also had some indicators of unmet need. So young people were asked, did you ever think you had a problem, but you didn't get treatment for it? And about a third said yes. Almost all of those had also had that experience in the past year. And then, do you currently feel that you need treatment? So the numbers here align pretty closely with, do you think you have a mental health problem? In that 56% said no, they don't feel like they need treatment. 11% were currently getting treatment, and we have 15% that say they don't know. So these numbers kind of map on pretty closely to what we heard about their perceptions about their need for mental health, and then sort of the next step is, do you need treatment for that, or are you getting treatment for that? So in terms of what young people had to say about that, in hearing some of their experiences in getting treatment in the past, we heard a lot about medications and some pretty negative statements about medications and how that was shaping the way young people were thinking about what they needed. So some of the quotes we heard, I would never take medication ever again because I felt like I'm not myself. I don't need medication to function. Another young person said, medication just zoned me out. I felt like I was on cocaine or something. I just didn't feel myself. We also saw young people really open with us in these qualitative interviews. And this young person actually talked about the difference between being able to talk to us in our qualitative interview, where we just wanted to hear their story, versus going to a mental health professional. So they said, I don't like when people pick my brain. See, this is different, this interview. I'll let you know everything because you're not trying to pick my brain. You don't want to put me on medication. They do. So definitely the perception on the part of some young people that providers have an agenda or, or before they're even going to listen, really they're just going to sort of jump straight to prescribing a medication or of treatment. We did also have young people who said they did want treatment, but maybe not medication, or that they had kind of come around to thinking about medication. So one young person said, I need counseling bad, because like I said, it's not all peaches and cream thinking about it, so counseling. I had a recent trauma. Another young person said, I don't like taking medication. I feel like I have more problems with it. Like I know that I can relapse, but like I want to be able to deal with my own problems without like chemicals in my brain and stuff. And we did that sort of in line with some other things we heard around self-reliance and young people really not wanting to use mental health treatment as a crutch, and medication in particular. It felt like it wasn't, they're not able to deal with their own problems if they've got medication. And then finally, a young person who had come around and was really committed to taking medication said, well, I didn't like taking the medicine, so I would not take it. And then when I finally, after I had my baby and I realized that I needed to start taking it, I just started taking it ever since. So there was sort of this process of coming to an understanding that the medication was really needed, that she kind of came to on her own through her experiences. The next set of slides is about help seeking and coping. We had two different measures that were focused on if you had a problem. The help seeking measure said if you were having a problem with your mental health, how likely would you be to seek help from? And then there's a variety of sources listed. I think it's interesting to note here. So young people, if they were having a problem with their mental health, almost half strongly endorsed that they would go see a mental health professional. But the top two people were an intimate partner or friend. And we did see the importance of these peer support networks as we were interviewing and talking to young people. Many young people really talked a lot about the importance of the people that were homeless with them or going through this experience with them, and the importance of their intimate partners and friends in helping them in managing a variety of things, but mental health as well. The next slide has help seeking broken down by perceived need. So we're really trying to understand. So those young people who identify that they have a mental health problem, did that change how they thought about how they would seek help versus young people who didn't see it? So the help seeking scale is hypothetical, but you do see differences where young people who are ready to say and acknowledge that they have a mental health problem were more likely to seek help from a mental health professional, like a doctor or another mental health professional for sure, but also from a variety of other sources. And we see that the people that don't know if they have a mental health problem, their help-seeking looked more like, their help-seeking preferences, I should say, look more like people who say they do not have a problem. So I think it's some indicator that those people who are saying they don't know if they have a mental health problem, which we saw 85% of them seemed to indicate they did have a problem, that some of it is about maybe hesitance around help seeking. They're not sure they want to identify as having a mental health problem, and they're not sure that they want to actually go and seek help for it. And we saw that here with the scale. The next scale was about coping. So it basically asked if you're having a problem with your mental health, what are some of the things that you do? And these are just there was a scale, but this is from the high end of the scale, who do these things often. And so the first four here, anger, using drugs or alcohol, sleeping, or trying not to think about it, are kind of avoidant coping strategies. That would be, sort of less recommended or less positive ways. And we see young people endorsing those definitely the lowest. And so young people weren't gravitating, or at least they weren't telling us they were gravitating towards these less positive coping strategies. We did see young people really talking more about these cognitive strategies, like thinking about how things will get better in the future, realizing that I'm strong and can deal with whatever comes my way, trying to learn from a bad experience. These were all cognitive type strategies that were strongly endorsed by a lot of young people. And in the next slide, you can see that we once again broken down by perceived need. that there were some differences between young people who say yes. Actually, young people who say yes were more likely to endorse some of these avoidant type coping strategies. So those who say they have a mental health problem were more likely to tell us that they use their anger or drugs and alcohol or sleep to manage those problems. And the don't knows here looked a little bit more like the yeses. The red bar, you can see there's a couple places where people who said that they did identify that they didn't have a mental health problem were actually more likely to endorse it. Is some of these cognitive strategies like realizing I'm strong and can deal with whatever's bothering me, thinking about how things will get better in the future. And so I think that's an indicator of potentially the types of strategies and the type of supports that may be more attractive to a group who's less willing to identify as needing mental health or having a mental health problem. And just a few quotes from young people around some of these coping strategies. We did hear a lot in the qualitative interviews about substance use and using substances to manage mental health problems. Statements like, I smoke my pain away, and I'm just going to sneak off, go buy me a blunt, and smoke by myself. And these were specifically ways that young people identified they manage their mental health. Spirituality, we saw in the measure that there was a big difference. Either young people endorsed spirituality really highly or it was very low. And for those who really identified with that, it was a strong sense of support. So we heard statements like, I just pray. Sometimes you got to pray. You got to pray to God. Sometimes you have to let him handle it. So that being a source of support. And then we heard young people talking about mindset and changing the way they're thinking as a way of getting through their situation and managing mental health. So I take every day at a time because I feel like if I don't, I'm going to get overwhelmed and I might lose myself. Another young person said, I look at every day as a blessing. So I just want to give a quick acknowledgement to our funders before we move into implications and recommendations. The Greater Houston Community Foundation generously funded the work that we did in Houston. So we definitely want to give a shout out to them. So moving to implications and recommendations. So I just want to sum up based on some of the things I said before I turn it back over to Matthew, just a couple of the recommendations for young adult homeless service providers that we see coming out of this data. So including natural and peer supports, I talked about that earlier, but thinking about ways that we can engage and involve not just the young person, but the support people, potentially the support people that are with them in shelters and drop-in centers, in understanding and education around mental health symptoms and ways to support people that are experiencing mental health symptoms. Because that seemed to be kind of a natural built-in place that young people are gravitating for help. We definitely heard a lot about prior experiences with treatment, especially medication. And so that's just something for providers to keep in mind and trying to work with young people. Really, I think listening first about what it is their preference, how are they seeing their own symptoms, what is their preference for how to manage those, and how are they feeling about medication before deciding on, a course of treatment. Also, assessing and recognizing that substance use is often a part of the way young people are managing symptoms. And so just kind of the strategies that we use to ask about that and talk about that with young people, just being sort of starting from a place of recognizing that that's pretty normal among this group and trying to get that information so we can effectively help them to develop positive strategies for managing their mental health symptoms. Exploring different language for mental health, modifications for specific groups. So I guess thinking about, I guess we saw that there were certain young people who really didn't identify with even the language around I have a mental health problem. But there may be different ways of talking about this. We've heard young people in other studies talking about my anger or my moods or my aggression, or they have listening to the young people themselves about how do they want to describe what they're struggling with, and then using that as an entry point to help introduce strategies for managing that. And we saw that utilizing cognitive strategies may be particularly appealing, that those seem to be where young people are gravitating anyway. And so those may be some good ways to build on, particularly for young people who aren't readily identifying as having a mental health problem. And then finally, we are seeing some members of the research team that were involved in this study even are developing interventions around mindfulness and helping young people to just tolerate distress in the moment and develop coping skills to just sort of manage day-to-day stress. I think that's sort of a built-in easy one if you're in a situation where you're a homeless service provider, you're in a drop-in center, you're in a shelter. Teaching some mindfulness strategies can really help young people in a moment-to-moment, real time to sort of manage their own stress and regulate their emotions. So I'm going to turn it back to Matthew for some additional comments.
Thank you. So, coming from a provider standpoint, and one thing I didn't mention is my background before coming into working here at Portland State is I ran a McKinney-Vento program for Oakland Unified School District and did work also in Baltimore with the McKinney-Vento program there. And so I just want to qualify that this is really coming from my personal practice experience rather than necessarily from research or research informed. I just want to give a disclaimer. So one of the ways where we really tried to broaden our scope and include folks that tended not to self-identify is just avoiding using the word, we avoided using the word homeless, especially in initial contacts and in our advertising. We changed our program name from, the McKinney-Vento Homeless Families Program to the Transitional Students and Families Program, which made a lot more sense to a lot of the families that we were serving because they didn't consider themselves homeless and would not have accepted service from us or sought services from us if that was our name. And also, we worked really hard to develop upstream relationships that could, and downstream relationships that could improve a warm handoff and a reception. So, for community providers, identifying the folks at the school district, I think is really useful in making sure that you can know each other and they can provide a real referral in terms of knowing your character and quality. Same with shelters. Legal aid groups are especially a great way for identifying the unaccompanied youth or the those that are transitioning out. Many of them who are trying to access things like subsidized housing or any kind of benefit program will need to emancipate. And we got, most of our initial referrals for unaccompanied youth from legal aid groups who were trying to support the young people that we were working with. But I can't stress enough that the best way, the best way to work with or to advertise yourself to this population, the unaccompanied youth in particular, is just by providing really great and non-judgmental service. It's a very small community. They tend to talk to each other. They tend to know each other. And they will, once we started really working hard to make sure that we were, creating kind of a safe place for them to come and get services and not being judged for being out of school for a while, we started to have them referring friends in quite a bit. Other places to work with, are some of the natural places like drop-in centers, child welfare programs, juvenile justice, and housing departments. And, it is worth pointing out that when it comes to shelters and drop-in centers, there does tend to be, in a lot of cities, specific places for LGBTQ youth to go. And a lot of times families or young people, especially unaccompanied youth that are leaving their housing situation because of their sexuality or gender questioning, will end up in these particular programs. So it's good to know those programs well so that you can provide a good referral and also so that those programs know to refer to you. One of the key things I found also is allowing the youth to set the priorities. Coming from kind of a community organizing background, the most important thing is that the young person comes back and they continue to get services with you. So even if what they find to be most important isn't what you think is most important, I always try to just go with that and try to get a quick, easy win straight off so that they feel successful in your relationship and they'll continue coming back. Another thing that I found really important, and this was supported by some of the research that I've done into to homeless school-age children and youth, is that stable housing is going to help, but it's not going to fix the underlying problems. Many of the problems experienced by youth are exacerbated. They're not caused by the experience of homelessness. So you tend to have a lot of people that have had the experience of being educated or had a lot of the risk factors associated with being poor as a lifelong cumulative stress. And this additional stress of experiencing homelessness creates additional hardship, but it's not the only hardship. And I'm not trying to say that housing isn't a key and important resource and right for these young people, but really remembering that it's not just housing that has caused the problems and caused the stress and risk in their lives. And so I also just wanted to provide a couple of resources for transition-age youth and unaccompanied youth that I gathered from the web, some of the main service providing websites, and just a chance to get a little bit more information, deeper information. A lot of them have like great materials, YouTube videos, or presentations if you're trying to educate people at your agency. I really highly recommend taking a look at these.
Thank you so much, Sarah and Matthew. We'll see if we can get to some of the questions that have been sent in, which are great. Thank you, everybody who's sent them in. One question for Matthew is, what do you think accounts for the lower rates of males, African Americans, and Hispanic youth being less likely to recognize their mental health needs?
I mean, I would say for males, you're going to talk about stigma and kind of, this is a generic answer, but the stigma that goes along with, being kind of tough, especially when you're young and resilient and, not wanting to show vulnerability, especially when you're in a homeless situation or a transitional situation, you don't have control over a ton. And having control over being willing to self-disclose over this stuff will be important. And that's probably in some ways magnified by some of what you would consider like traditional young male ethos, but that's an extremely generic answer. And then you also asked among African Americans and what other population?
Let's see. The question, Hispanic and African Americans.
So, and this is again going to be really generic, but African American and Latino, and just generally, generically, like minority youth tend to have less uptake of mental health services. And I'm not going to say anything, groundbreaking, but some of it has to do with not having providers that look like them. Some of it has to do with a history of things like, some of the terrible things that have been done historically in research and mental health and physical health, especially among African American populations, that has really created a enormous trust gap between providers and minority communities, and that's just something we have to work against every day, trying to do a better job and be ethical and show that we can, that we're not, the providers that came before us and just being an individual. But it's a challenge, and it was created by, the medical and psychological fields work over the last century.
I also, I can chime in a little bit. We've also done some other qualitative work, not through this study, but in other studies, where we hear young men of color talking a little bit differently about their mental health in ways that sort of stress more of an idea of self-reliance and wanting to be strong, and also viewing problems as more temporary and kind of rejecting that identification with a, like a label of mental illness, and just really viewing the problems very differently. And, when they're doing well, talking about that, what that means is basically sort of like getting over it, or not, sort of not talking about it. So there's, I think, maybe some differences around thinking about mental health and what that is, and then also sort of preferences around how you want to deal with that, and what's the strategy that kind of fits for you. And I think we have a mental health system that seems to fit better for some young people than for others.
We have another question. Maybe you could take this one, Sarah. Since unaccompanied homeless youth tend to access services, do you think these results might look different with youth who are not accessing services?
I think that brings up a good point about just sort of who's not represented in our survey. So these are young people. The results I presented are from young people who are using services, and there's a whole bunch of young people out there who are in, unstable housing situations who are not seeking services. So it's hard to know. I think that's a really big question that remains. Do those young people look different? Are their needs lower because they haven't decided that they need to seek service? Maybe it hasn't reached over the threshold to where they really are needing to get services because of a higher level of distress. But it could be just that there is sort of more isolation and depression. So it's really hard to know. I think that there are different, new researches trying to get and identify homeless youth differently than the way that we did it in this study, which was to go to service providers. The University of Chicago Voices of Youth Count through Chapin Hall, they've done a household survey. So that's a really different way of hopefully getting some information about people that have experienced homelessness that we would never see in other studies. And so keep an eye out for the results of that study. I think they'll be coming out soon. So I guess we'll see.
Excellent. We had another question related to substance abuse. Wondering if, when you talk about substance abuse, are you saying youth and young adults that are living with their families and because of their substance abuse challenges, they get kicked out? Or these youth and young adults have a place of their own, but because of their substance abuse, they're not able to keep up with bills and lose their homes? Do you have any sense of that?
It's both. It's both of those things. So I think that there's substance use crops up in a lot of different ways. That, when I was talking in the very beginning kind of about this intersection, so we have, so I think it starts even with some substance use issues in families that sometimes drive young people, that may lead to housing instability in the young people themselves. And then also young people who are using substances, that can really fuel family conflict. They may end up getting kicked out. They may end up deciding that they want to leave home and pursue, kind of have less rules and more freedom in a different situation. And then there are certainly young people who have gotten their own apartment and aren't able to maintain it because all the money is going to substances. There are also young people who end up on the streets and in unstable housing situations and end up starting to use substances because of the peers they're interacting with, because of the high level of stress they're experiencing. So it's really like all of those things. So it's not really an either or, it's like both and.
Mm-hmm. I think we can try and squeeze in this last question. Do you think there are LGBTQ youth who do not identify out of fear, or that were missed entirely because they do not go to those shelters or centers, again, out of concern?
So specifically in our study, I don't think we have a lot of under-identification within our group. That's certainly always a risk when we're, we have self-report bias. So the data that we have is based on what young people were willing and comfortable to tell us. I think that the spaces overall where we collected the data are affirming spaces, where, there's sort of, some of them were even LGBTQ youth-specific spaces, I think, maybe in one or two cities. I certainly, the young people who are not accessing those services, I think there's certainly some of that. I know that there are young people out there who are not accessing our services, and I think, you know, place to place, if there are spaces where LGBTQ youth don't feel comfortable, and then certainly we're not finding them. So I think that is, you know, it's something to be thinking about. It's a great question. I know our study overall is 28% LGBTQ. We find a lot of variation in cities around the percentages. So you'll hear 40% of young people identify as LGBTQ youth. And we see that in our sample in Los Angeles and New York, but not overall. So I think it varies city to city as well.
Well, thank you so much. That is all the time we have for today. Sarah and Matthew, we thank you so much for your time, and want to remind everyone that we do have whole resources on this slides that will be available when this presentation is posted, and look for that on our website along with this recording. Thank you everyone for joining us.
Thank you.
Bye.